Hello, and welcome to the Osteogenesis Imperfecta Foundation's podcast series. My name is Danielle Simber, and I am the Communications Manager at the OI Foundation. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta presented by an expert in the field of OI and rare bone disease. The podcasts are part of the ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. Our podcast today will focus on treatment implications of genetic heterogeneity in OI. We're very excited to have with us today Dr. Peter Byers. Dr. Byers is a University of Washington professor of pathology and medicine, as well as a member of the OI Foundation's Medical Advisory Council. Thank you so much for being with us today, Dr. Byers. We'll jump right into the first question. We know that osteogenesis imperfecta is known to be an extremely heterogeneous, rare genetic disorder. Can you explain a brief history of the types of OI and how it has evolved?
Sure. We've known about OI for a long time, and there are stories written about Ivor the Boneless, who was carried into battle on a shield and was thought perhaps to have osteogenesis imperfecta. But the real study started in the 1700s or so, and there are research theses written at that time to characterize families that had many people involved, and you could see in retrospect in looking at them that they had to be dominantly inherited because they went from generation to generation. And for a long time it was thought that there were two kinds of OI, one that appeared at birth, that was called OI congenita, and another that appeared when fractures appeared later, and it was called OI tarda. And that kind of classification stayed in the literature until the mid-1970s, when David Solenz did an experiment. The experiment was a very simple one, and that he reviewed all the cases that he could find in Victoria, the southernmost, easternmost state in Australia. And he looked at several things. He looked at the clinical pictures, he saw the patients, he characterized their physical features. He looked at the x-rays, and he took a family history to ask whether there were siblings but unaffected parents, or whether there were parents and children involved. And on the basis of that, he thought that he could distinguish four different characteristic types. One, which was mild, and when people had blue sclerae, they were about average height. They usually didn't have bony or tooth deformities. And that was called a mild dominant form, and it became what is now known as OI type 1. He could distinguish a very severe form in which there was perinatal lethal involvement, and almost all these children died in the perinatal period. And because originally there were two different kinds, that was tarda and congenita, that severe congenital or congenital form ended up being called OI type 2. And then OI type 3 was, and at the time he thought it was recessive. And then another one, not quite as severe, was in between the two, called OI type 3, but it was on the severe end. He also thought that was recessive. And then he thought there was a rare form in which there was some bony deformity. They were shorter than the people with OI type 1, but not nearly as severe as the ones with OI type 2. And that became OI type 4, which he thought was a relatively rare condition. At the time, there were no real studies indicating what the cause was, but very soon after that, people started studying cultured cells from skin as a surrogate for bone, and found that most of the people who had osteogenesis imperfecta had one of two different kinds of abnormalities. Their cells either made about half the normal amount, and that was characteristic of OI type 1, or they made abnormal collagens, which could be detected because when the chains were separated by gel electrophoresis on polyacrylamide gels, there were shifts in their position on the gels, and not because there was something added or removed from the chain usually, but because there was a change in the modification of the proteins. So on the basis of that, it was clear that there were some people, a small number, who did not have primary had neither one of those. They made normal collagens, and yet they clearly had OI. And beginning in the early 1980s, mutations were characterized in type 1 collagen. And the majority of people who made half the amount of type 1 collagen had mutations in one of the genes that made that, called COL1A1, COL1A1. And they essentially made half of the normal amount, and that was because they had particular kinds of mutations in one copy of that gene. The other people made the gene show that there would be abnormalities in the structure of the protein, in the sequence of the protein, that were very subtle, and they might replace one amino acid out of more than 1,400 amino acids with a different amino acid. And that was the other very common form of OI. And there were people who did not have abnormalities in either, and the sequencing ultimately did not find alterations in either of those two genes. So from there, there were a number of different kinds of things that occurred. There was a rare form of OI that was identified as being recessively inherited, and that was identified as Brooks syndrome, or form of Brooks syndrome. And that was in the late 1990s. But the real start of the evolution of the identification of proteins came in the mid 2000s, when it was the confluence of a number of different kinds of things. First, there was family studies and genetic studies. The first was in a group in northern Canada of the First Nations, as they call them, Native Canadians, that was clearly recessive. And the group from Montreal was able to map the gene to chromosome 3. At the same time, Roy Morello, who was a graduate student in Italy, had identified a protein that was thought to be a bone or cartilage protein, went to Baylor to begin to look at what effects mutations in that gene could have in animals, and recognized a clinical picture that was similar to the one in Canada. The mouse protein and then the human protein mapped to the right place in the genome. And this protein called CRTAP was then identified as the source of abnormalities. That protein was known to interact with other collagen proteins and with other proteins itself. And by careful mapping of proteins that were involved in collagens and collagen processing, a whole series of other genes were very rapidly identified during that time by many of the people who are part of the medical advisory group in the OI Foundation. And then the next thing that happened, so those were using candidate genes, that is, proteins that seemed to interact with collagens were identified that way. And then what happened was that a method for really looking at all of the genes in our genome was developed, so that what's called whole exome sequencing, which allowed people to take families in which there were forms of OI that hadn't been identified, or for which the basis had not been identified, sequence all the coding sequence of essentially all the genes, and then find the variants in those genes that were abnormal and which were seen only in the people that were affected in those families. And that led to a second rush of new genes that were identified, so that now there are more than 20 genes that are involved in producing osteogenesis imperfecta, all of which can now be tested for and are usually tested for in a single way.
Can you explain the different types of diagnostic testing for individuals living with OI?
When the studies were first done, they were done using cultured cells from skin biopsies. And that was done because those cells made a lot of collagen. The collagen is made from the same genes that make collagen in bone. It was easier to grow them than to grow cells. And the techniques for protein analysis were much better developed at that point than the techniques for diagnostic gene or gene sequencing. And so that became the standard by which things were done, and was the basis for diagnostic testing up until the mid-1990s. At that point, much more efficient DNA sequencing developed, and so the technology shifted to trying to identify mutations in genes, and that's now become the standard sequencing. And now sequencing is done taking a small amount of blood or saliva in some cases, and extracting the DNA from the appropriate cells, and then sequencing all of the genes that are involved at the same time. It's just as efficient to do that as it is to try and sequence one of the genes, and the cost is exactly the same. So that's become the standard for sequencing at this point. There are some things that are not done or not found that way. So, for example, almost all the genes that are involved in osteogenesis imperfecta have their coding sequences, that is, the sequences which are important for making a protein divided into multiple different sites along the one gene. And in order to be functional, those coding sequences have to be joined together in an RNA molecule that's made from the DNA in a process that's called splicing. So about 15 to 20% of the mutations in some of the genes have mutations in the splicing sites, so that the rules for saying cut here and join there aren't followed well, and as a consequence there are pieces of the DNA that are left out, or a variety of other kinds of things can happen. And so in order to determine if those, what actually happens as a consequence of mutations in those sequences, you have to have cells that make the proteins to be able to study them. And those cells would have been available from the cells that use protein studies, but now it's a whole special adventure to get them and to study them.
Does a genetic diagnosis make a difference in the approach to treatment for children or adults?
That's one of the major questions that we'd really like to answer. The fundamental sense is, well, it really should. It helps us, it does help really to understand differences among people who have OI. So, for example, people with OI type 1, the most common form of OI, make half the normal amount of collagen. And so you might expect that if we could bump up the amount simply by doing any kind of manipulation, it would make a difference for them. And so our pathways to treatment might be quite different. Most of the other people who have it make an abnormal protein, who have mutations in the same gene. And the strategy for dealing with them and helping them would be quite different. You might want to turn off that abnormal type copy of the gene and make them into having an OI type 1, for example. We don't have so we know from a clinical perspective that people are quite different, and that the outcomes and potentially the response to medications would be quite different, although they're not really stratified in that way. What we do know from the use of bisphosphonates, for example, is that you may get better outcomes with people who are more mildly affected. And in fact, if we were going to develop a drug, we'd really like to have better outcomes for people who are more severely affected. So, and the other thing is that in the evaluation of any kind of treatment that you would do, you'd like to know how heterogeneous the population was. That is, how many different kinds of things were wrong, how many different classes of mutations, how many genes were involved, and whether your population was mostly people who had the same kind of mutation or people who had something different. So I think in that sense, we haven't taken advantage of that information at this point very well, but it would be the kind of thing that we really ought to have, and it ought to be part of everything that we do downstream.
Great, thank you. When would you advise that a patient, child or adult, or the physician of a patient, to request genetic testing in addition to a clinical evaluation? Is it most helpful in cases that a diagnosis is unclear, or would it be helpful in any case? In your experience, what does it depend on? Is it the insurance, clinical team, institutional protocol?
And so in a sense, because I developed laboratories that did the diagnostic testing, I'm always interested in it, and my fundamental feeling is that everybody with OI should be tested so that we know about it. That's a hard route to justify if the diagnosis is absolutely clear and if you can be pretty sure about what the basic mechanism is. So, but there are a number of different things for almost every family. The question is asked whether we're at risk for having another child. And if the family is, if there clearly are multiple generations of the family, then the answer to that is very quick and very easy. And so you can say, well, if you're affected, you have a 50% chance of passing on the altered copy of the gene, and the ones that get that copy of the gene will develop osteogenesis imperfecta. We know that there's some variation in the clinical manifestations, but that's the fundamental idea. So for the families where there's a very severely affected child that dies in the perinatal period, there are two categories of condition. There's one where that's a recessive disorder and the recurrence risk is 25%. And if we can find the copy of the gene, and that means that each parent will be a carrier. So if we can identify the mutation in the child or the mutations in the child, then we can assess the risk, and we can also provide ways of doing either prenatal detection that can be done very early at, say, 10 weeks or so, and maybe possible to do even earlier than that as serum detection of mutations becomes available in that specific context. Or to provide information leading towards pre-implantation genetic diagnosis, where fertilization occurs in the test tube and the unaffected embryos can be selected. And those unaffected embryos could be those that inherited neither affected allele or affected one allele from only one parent, and so have that. So 3/4 of the embryos would be available for implantation under those circumstances. The same is true there's a small proportion of people who have a very severely affected child who actually the child has a new dominant mutation, but one of the parents is mosaic for the mutation, which means that they actually can have another child with that. So we've suggested that all parents in that situation be tested, because we think that about 1 out of 15 to 1 out of 20 families that has a child with a new dominant severe mutation in one of the type 1 collagen genes is mosaic. And so by not knowing, it means that that ordinarily they would be counseled all that the measured recurrence risk under those circumstances is somewhere around 2%. But for the individual families with a mosaic parent, it can be as high as 50%, although we've never seen it quite that high. So that's a way of dealing with that kind of problem. That's also true for new mutations that occur even in OI type 3 or OI type 4, that there can be mosaic parents. So the distinction between the type of inheritance becomes important for future, for family planning in that context. And so that's important. I think that, so under those circumstances, testing at or near birth is really important. And I think that the testing will evolve so that we can do during pregnancy, if it's an affected father and they've not had an affected child before, early serum detection that's now being, maternal fetal serum that's now used for things like detection of Down syndrome, could be used to detect the presence of the father's single altered copy of the gene, which would give rise to OI in the child. So I think that there are all kinds of things that are evolving. It's used to some extent in the evaluation of children in the emergency room when they come in with a fracture. although it's the end of a long protocol, but in our studies that we've done, we've recognized that about 5% of the kids that are tested ultimately, and that's not 5% of the kids that come in with a question of trauma or non-accidental injury, but it's after the clinicians, the child abuse team, the geneticists, and whoever else may study the child, we find about 5% of them do have mutations in one or more of the collagen gene or the OI genes. And so there's still that place to try and make things work. And we found that the decision to test really depends a lot on, one is the perceived cost of testing. So the perceived cost of testing is less than an MRI, it's less than many X-ray series and things of that sort. And it depends on where the testing is done, but can range anywhere from a few $100s to about $1,500 all told. So it's, as a medical test, it's not that expensive, and in fact is less expensive than some of the things that we ordinarily do. For people who are unaware that testing is available, it doesn't ever get tested. I think that it's the advantage of people seeing clinicians who know a fair amount about OI or who have centers for doing it. And I think that the rate of testing increases at that point, in part because with somebody new, you're not sure whether it's recessive or dominant. That may mean a difference in family planning. It may mean a difference in whether drugs would be effective in treatment, for example. Insurance generally, in our experience, pays for testing if they're asked appropriately. But there is institutional difference. There is a difference among clinical teams. And there are a lot of people who take care of kids with OI who feel very confident that they know exactly what's going on, even when sometimes they might not.
That's great information.
Okay.
Thank you so much, and thank you so much for joining us today, Dr. Byers.
You're very welcome.
Listeners, if you have any questions or comments, please contact the OI Foundation at bonelink@oif.org. You can find all recorded OIF podcast episodes at www.oif.org/OIF podcast. Thank you for listening, and stay tuned for the next episode.